that they spend on clinical services and qualities in the large group market and less than 80% in the small group and individual market. As an example of that, $4.2 million have already been rebated to Alabama consumers. And then lastly, there is a requirement that health plans have to justify in a public forum any increases in their rates, and that's subject to either federal or state review depending upon whether or not the federal government deems the state having adequate powers to regulate insurance. All right, now we move to the insurance exchange. One of the more confusing, as I went through, one of the more confusing parts of this whole package. An exchange is nothing more than a marketplace. There are three types of exchanges. The state of Alabama could have opted to run its own health insurance exchange. We could have done something called a partnership exchange where we and the Fed share responsibility, or we could have defaulted to what's called a federally facilitated exchange, and we'll also hear it referred to as a federally facilitated marketplace. Alabama has opted to the federally facilitated marketplace. So the only thing the state of Alabama will do with the exchange is the state insurance department will undertake state regulations of those portions of the insurance plans that come under state regulatory authority. In other words, there will be a requirement that if a plan is going to be issued on the exchange, it has to have a state license, that sort of thing. But in terms of which plans, what their benefits are, that's all going to be federally determined. Now, so we've opted for a federally facilitated exchange. Now, there are two, in the exchange, in this marketplace, there are two pools of insurance. One pool is for the individual. It's called the American Health Benefit Exchange. And the other is for the Small Business Health Option Program, or the SHOP program. So that company with 75 employees who wants to buy insurance for their employees, they will buy it in the SHOP exchange. The plans, the benefits in the plans will be the same as the benefits in the individual exchange. The access to the exchanges is limited to U.S. citizens, legal immigrants, and people who are not incarcerated. The exchange has to link to both the Medicaid system and the child health insurance system. So, for example, a family applies for insurance. It turns out that their income is too low to qualify for insurance in the exchange. They get routed then whichever is appropriate, either the Medicaid or the child health insurance program, depending upon their income. Income ultimately will be verified in both state and federal exchanges. For example, the IRS, if you make a claim for a subsidy, a insurance credit to help fund it, the IRS will have your prior year tax returns and will be able to validate whether or not you're entitled to that. And in fact, there is a $25,000 penalty for making a false application to the exchange. We first just look at the individual exchange. All right, in the individual exchange, all plans are what are called QHPs, qualified health plans. Qualified health plans have to offer 10 services. They have to offer hospital services, ambulatory services, emergency services, newborn and maternity care, mental health and substance abuse, pharmacy therapy, rehab, laboratory, pediatric care, including dental and vision, preventive wellness, and chronic disease management. So every plan that's going to be sold through the exchange, whether in the individual market or whether sold in the shop market, are going to offer those common benefits. There are certain people who are not eligible to buy insurance in the exchange. Medicare enrollees can't buy insurance through the exchange. Medicaid enrollees cannot buy insurance through the exchange. CHIP enrollees can't buy insurance through the exchange, and employees who have access to employer-sponsored insurance can't buy insurance through the exchange unless the coverage, it costs more than 9.5% of the employee's income, or the plan is not, the plan that the employer offers is not a qualified health plan. Large companies with more than 100 employees cannot buy insurance in the plan at least till 2017, and then there's the potential for expanding that. Illegal immigrants cannot buy insurance through the plan, and you cannot provide insurance to people who are incarcerated through the exchange. There are 4 levels of plans, and they are simple. They're bronze, silver, gold, and platinum, and they are delineated based upon what percentage of the cost of health care they pay. Bronze pays 60% of something called actuarial value. Actuarial value is they create an ideal population and predict how much health care ought to cost for them. A bronze plan will pay 60%. A silver plan pays 70%. A gold plan pays 80%, and a platinum plan pays 90%. All right, I'm a low-income individual, and I go and I seek insurance through the exchange. There are subsidies, and there are premium credits and cost-sharing subsidies available to me if my income is between 100% of the federal poverty level and 400% of the federal poverty level. As an individual, think $11,000 to $45,000. For a family of 4, think up to $94,000. There's a potential subsidy. Specifically, for an individual, the federal poverty level is $11,490, and for a family of 4, it's $23,550. At that level, the premium credit that you will get will ensure that your insurance will not cost more than 2% of your income. At 400% of the federal poverty level, so for example, that's an income for an individual of $45,960, and for a family of 4, $94,200, your insurance will not cost more than 9.5% of your income. On top of that, remember, these are all based off the silver plan. So 70% of your cost is covered, but you still have a 30% copay. Well, that's brought down further by what are called cost-sharing subsidies. So, for example, if your income is between 100 and 150% of poverty, you will get another subsidy so that 94% of the cost of your care is paid for. You're stuck with only 6%. At 200, 250%, 73% is paid for. So you still have 27%. All of these are tied to income and family size. So the poorer you are, the less your insurance will cost, the greater the subsidy you'll get. In the SHOP exchange for business, it's available to businesses with up to 100 employees, provides the exact same access to plans, the same types of plans as are in the individual market. And again, we talked about for very small businesses, 10 employees or fewer, 25 employees or fewer. There are tax credits that will pay up to 50% of the premium. Now, so we've talked a little bit about what the ACA does for the individual mandate, the employer mandate, a little bit about what it's done to private insurance. We've talked a little bit about what it's done, what the exchanges will look like. And again, remember, the exchanges start, in theory, on October the 1st of 2013. You'll be able to enroll on October 1st of 2013, and the insurance takes effect January the 1st of 2014, and the open enrollment period on the exchanges goes to, I think it's March the 30th of 2014. It's a 6-month open enrollment period. All right. The Affordable Care Act and Medicaid. The Affordable Care Act originally required all states to expand their Medicaid programs so that individuals making less than or equal to 133% of the federal poverty level were included in the program. Now, you will hear in conversations a number 138%. That's because there is a new way of calculating income called MAGI. It doesn't have anything to do with wise man. It basically is the adjusted gross income, and when you actually calculate it into income, what it does is it artificially raises income by 5%. So you will hear people talk about either 133% or 138%. They're the same number. It's 133% with MAGI. It's 138% compared to where we are today. If you look nationally, over half of the uninsured individuals are people who would qualify for a Medicaid expansion. In Alabama, 53% of that 670 to 700,000 are individuals who would qualify if Alabama expanded Medicaid. But as you also know, the Supreme Court, in its landmark decision last, I guess it was either June or July, they run together, said that the states could not be compelled and could not be penalized if they chose not to expand Medicaid. And the governor has said at this point Alabama is not expanding its Medicaid population. As I think you've also no doubt heard, there's a lot of conversation around the first 3 years. The first 3 years, the cost to the state is zero. In subsequent years, those additional enrollees, and the number is anywhere from 320 to 380,000, the state would begin to pay progressively more, starting at 5% in 2017, moving to, by 2020, paying 10% of the cost of those extra enrollees. There is another issue, though, in Medicaid, and that issue is something called the Woodwork effect. We don't get this enhanced matching rate in Medicaid for people who today are Medicaid eligible but who have not yet enrolled because they're eligible under our current system. When the exchange gets operational, some of those folks are going to apply for insurance. They're going to get referred to Medicaid. Medicaid will have to cover them, and since they were already eligible, we'll cover them at our current match rate. We expect that number to be about 23,000 people with a state cost of about $8 million additional dollars. Another thing the Affordable Care Act did was it increased primary reimbursement for primary care physicians up to the Medicare rates for 2014 and 2015. And fortunately, the federal government gave the states the money to pay for that increased reimbursement, but only for 2 years. So in 2016, states either have to roll their reimbursement for primary care physicians back to where it was in 2013 or find additional dollars to support that bump. Okay? So that's sort of, again, Alabama has at this point chosen not to expand its Medicaid program. Medicare. My dad is extremely concerned about this, and every time I see him, I have to re-explain that he doesn't have to get any new insurance. But here's what the ACA does for Medicare. First, it is projected that under the Affordable Care Act, $716 billion will be cut out of Medicare expenditures over the next 10 years. Everybody understand what that means. That does not mean that the amount of money that we spend now will go down by $716 billion. It means that the rate of growth will be brought down by $716 billion. Those dollars are going to be achieved by reductions in payment to Medicare Advantage plans, cuts in payments to hospitals, physicians, insurance companies, cuts to home health agencies, nursing homes, hospice, and importantly for Alabama, hospital disproportionate share payments used to pay for indigent care. As an example, we're going to lose about $14 million this year that go to hospitals. In theory, that $716 billion is going to be reinvested into Medicare to help close the Part D donut hole. And in fact, by 2020, it's supposed to disappear. Because of some of those funds already being reinvested, it's estimated that there's been about a $50 million reduction in what Alabama Medicare recipients would have already spent on drugs, but for that change. And I think all Medicare recipients know they now have expanded preventive services and wellness visits.